So without further ado, welcome to this evening's webinar, and I'm going to hand it over to Dr. Hollie.
Thank you, Natasha. Welcome everyone to the Spotlight on Health, sponsored by the T. Colin Campbell Center for Nutrition Studies. We're glad you joined us tonight. We have an exciting conversation ahead of us. We have Dr. Tom Campbell, who's going to share with us about research that he and his wife and his team at University of Rochester have been doing. Exciting research, and in the area of metastatic breast cancer. And then we're going to also talk about some research he's done on diabetes as well. I want to start with saying that the T. Colin Campbell Center for Nutrition Studies is committed to funding research to explore the role of diet, specifically a whole food plant-based diet, in preventing and treating chronic diseases. In realizing this commitment, CNS provided startup funding to the University of Rochester to explore the role of diet in preventing and treating diseases. This research was developed by Dr. Tom Campbell and conducted by his team, including his wife, Dr. Erin Campbell, at the University of Rochester. They later received additional funding. Tonight, you'll hear about some of the groundbreaking research that they have conducted. And here to share this is Dr. Tom Campbell. He is a physician, a best-selling co-author of the China study, researcher, and educator. He has developed groundbreaking clinical and research programs at the University of Rochester and has worked with many hundreds of patients to prevent and treat illness using optimal diet and lifestyle. He is also author of the China Study Solution, the practical how-to guide to implement the China study recommendations, and of course, co-author of the Plant-Based Nutrition Certificate offered by the T. Colin Campbell Center for Nutrition Studies. Dr. Campbell is a graduate of Cornell University, went on to get his medical degree from the University at Buffalo School of Medicine. He completed residency training in family medicine at the University of Rochester, Highland Hospital. He has published multiple papers in the scientific literature and has presented widely on the topic of plant-based nutrition. And oh, by the way, he's completed multiple marathons. Welcome, Tom. Great to see you tonight. Glad You're here to share this exciting information with us.
Thanks for that. Thanks, Mike. Good to be here.
So let's launch it into this. I'm going to read the purpose of your paper. You have two purposes. And I will say that there are two papers that were produced on the metastatic breast cancer topic. One focused on weight, cardiometabolic, and hormonal outcome. The other feasibility, nutrient, and patient-reported outcomes. They're the same patients focusing on different results. So the purpose of the first, breast cancer treatment, is associated with weight gain, obesity, and its related cardiometabolic and hormonal risk factors. And this has been associated with poor outcomes. Dietary intervention may address these risk factors, but limited research has been done in the setting of metastatic breast cancer requiring systemic therapy. Secondly, quality of life is among the most important outcomes for women with metastatic breast cancer and actually predicts survival. Quality of life is negatively impacted by cognitive impairment, fatigue, and weight gain. And the authors assessed whether a whole food plant-based diet would promote weight loss is feasible and might improve quality of life. So Tom, start with some of the background. What did you and your team, what did you base your study on?
Well, there's quite a long history of diet and cancer research, of course. But if you look back through time, a lot of it is observational. So there's a pretty good body of literature, for example, that breast cancer is more common in some places than in other places. And then there are sort of observational studies looking at migration between those places. There's migrant studies showing that if someone moves from a low risk area to a high risk area, they adopt the risk of getting breast cancer similar to the place to which they move. So they don't change their genes, they change their environment, and their risk, seems to change in populations when they move. And then there's been a fair amount of animal research looking at diet and cancer, and diet and breast cancer probably has gotten a fair amount. But you can look at animal experiments in rodents looking at certain nutrients or certain food components and breast cancer progression and so forth. But if you go past that, the observational research and the animal research, and a lot of that suggests that nutrition is likely to matter a significant amount, right? But if you go past that and think, okay, well, let's see how it's tested in humans, you run into some big gaps in the literature. And you'd think it would be tested given all that background of observational research and some of the animal research, but it hasn't really been tested. In fact, I don't know if you have had a chance to read The Future of Nutrition by my dad, but he talks about some of this history, and gosh, hundreds of years ago, there were proposals to study diet and cancer, diet as a therapy in human patients with cancer. And it wasn't done. And, you look back, through the recent past, it hasn't really been done as sort of, a typical randomized control trial with diet as a therapy. So we decided to do it. We decided to embark on a research program to look at this. But, it's a bit complicated because breast cancer, it's a little hard to study cancer. Cancer can be very slow, and it's kind of hard to see what cancer outcomes there are. We thought about doing a study with early stage breast cancer, because there'd be, in some ways that would be easier, fewer complications. But with early stage breast cancer, fortunately, the recurrence rate or cancer event rate is very low. So if you ever want to look at cancer outcomes, change a group of women's diet and then look at cancer outcomes, you'd need to get a huge number of women to get enough cancer recurrences and cancer outcomes. So, and that would be tens of millions of dollars, So early stage breast cancer would be hard to study cancer outcomes. So we kind of settled on looking at metastatic cancer and breast cancer. And the reason is this, because you can actually track the cancer. Theoretically, you actually have cancer to track. And you can see cancer-related outcomes in a smaller group of people much faster. The downside is that it hadn't really ever been done before, and there's some big, huge questions before we embarked on a giant study looking at cancer outcomes over a long period of time. We wanted to understand, since this hasn't been done, can we recruit women with metastatic breast cancer? Oftentimes there's a lot of comorbid illness and cancer therapies and issues with cancer therapies and so forth. Could recruit women to a massive dietary change. And if they adopted a massive dietary change, how did they tolerate it? We go from one day to the next, we're going to double your dietary fiber. Are we just going to mess up cause a whole bunch of side effects with loose stool, or, with these women are on cancer therapy? And then are they going to stick with it? And then, of course, what are the preliminary effects? Do we see that it's making a difference in some of the things? So that what I'm getting at is this is sort of a feasibility. Before you invest millions and millions of dollars in a big study, you got to understand some basics about whether this is feasible. Are these feasible things to ask? So this first study that we did is really kind of what we call a feasibility pilot study. It was a small study with 30 women with metastatic breast cancer on cancer therapies, on systemic cancer therapies, and we gave them a whole food plant-based diet for 8 weeks. And it's interesting, metastatic cancer, you think changing to a restrictive diet is, one of the reasons we did a pilot is to sort of, you think metastatic cancer, you want to change to a more restrictive diet with, what you can and can't eat. People get a little nervous about weight loss and so forth. But breast cancer is kind of interesting, as you alluded to when you asked your question. Breast cancer, the majority of women who are treated for breast cancer gain weight through their treatment. And, if you look at obesity at diagnosis, so women with a higher amount of excess weight at diagnosis have worse outcomes. Women who gain more weight through treatment, sometimes that's been associated with worse outcomes as well. So if you look at the metastatic cancer population, this is, and just to be clear for everyone, this is cancer that's spread from the breast to distant parts of the body. If you look at that population, that the rates of obesity in that population are just as high as the general public. If you look at trials of women on chemotherapy with metastatic disease, the rates of obesity are just as high as the general public. So, there is this kind of interesting opportunity, I think, where there's a lot of reasons to think nutrition might make a difference, but that's just one of them, is that you have, an obviously food-related, nutrition-related state, metabolic state, excess weight, that's been associated with bad outcomes. And so, what are the preliminary effects of changing diet, to look at that type of stuff. So that's kind of the broad overview, the background of what we did in this, this feasibility pilot trial.
Yeah. Okay. Great. And the obesity part to this puzzle is very important because in addition to, as you mentioned, they have many times worse outcomes, it affects their quality of life as well. And your studies showed that, and that, gaining weight in addition to having breast cancer and undergoing all this treatment affects their quality of life in a different way, just from the obesity alone. So, yeah.
Right.
So where did you get these patients, and how did you, select them and sort through them?
So part of the whole reason of doing the feasibility pilot was because, I'm trained I'm in the Department of Family Medicine at the University of Rochester. So, to see if this is feasible, a big part was recruitment. Are we going to be able to go to an oncology group and have them turn over their patients and do this crazy diet? That's pretty restrictive. And we found a wonderful partner at the U of R, Pluto Cancer Center, where they see most of the breast cancer patients here at the University of Rochester. University of Rochester is a pretty big medical center. I don't know, it's one of the top few, I think, in medical groups in the state of New York. And so we found everybody locally through the University of Rochester. There were some patients from a little further away regionally that found us through, information postings or clinicaltrials.gov or support groups, that type of thing.
Okay, yeah. So describe for us what these patients went through. In other words, you had an intervention group. It was about 2/3 of the study subjects, and then a control group that was about 1/3 of your study subjects. Explain the difference, what you did with the intervention group and how you accomplished, getting them on this whole food plant-based diet and getting them to adhere to it.
Right. So our general approach and our theory, in our interest in our research is looking at, does food matter? So we want to give study subjects, study participants, every single possible resource we can to make large dietary changes and stick with it, for the duration of the trial. So what we did is women were randomized. They were randomly put in either intervention or the control group. In the intervention group, we actually gave them 3 prepared meals a day plus snacks for the entire 8 weeks. And it wasn't a calorie controlled diet. It wasn't targeting a specific fat grams or, nutrient grams. It was entirely whole food plant-based. So there was no animal products at all. And we also excluded anything with added oils or solid fats. It wasn't necessarily low fat, natural peanut butters and nuts and stuff were allowed. So the high fat plants and some of the, a little bit of the dried fruits and a little bit of added sweeteners were allowed. But mostly, whole plant foods. And for 8 weeks, women could add their own food. They could take our meals, and if they didn't want that meal, they could make their own or use their own food from the grocery store. So they could eat as much as they wanted, whenever they wanted. And in fact, we frequently told them, you're going to have to eat more food. Please eat more. Don't get hungry. And they did that for 8 weeks. We also met with them once a week. So we gave them, education about why they were doing it. What are some of the health effects of a whole food plant-based diet, some of the behavioral things, as well as some of the practical things, shopping guide and food guides and, that type of thing, resources online, coaching, that type of thing. So it was a very intensive intervention. The control group just continued their normal care. I should mention too, they also got a multivitamin, a Centrum multivitamin. The control group just got the multivitamin and otherwise no dietary change or education. We checked in with them a couple times during the study, but they did all the testing, and then after the 8 weeks, they had as sort of a thank you, which was intended to help people stay engaged in the study. In the control group, they got an abbreviated 2-week food provision, all meals provided and education, so that they also could benefit if they wanted to learn about this type of diet, that they could benefit and have the resources and apply it to their life.
Yeah, I thought that was interesting and a nice reward for them. Sorry you got randomized to the control group, but hey, we're going to give you some of the good stuff here.
Right.
That was really good. And just to clarify, when patients in the intervention group, when they added their own food, it had to be, quotes, on plan, correct?
Correct. Yeah, we had pretty intensive sort of one-on-one instructions about what was on plan, what was not on plan, with the food guide and so forth. So,
and the majority, or maybe all of the patients in the intervention group were new to the whole food plant-based idea?
Yeah, that was an exclusion. If you were vegan or whole food plant-based, you couldn't be in the study. So yeah. Everyone.
So that's an important point, because these were people that were new to this, and the compliance was very, very high, correct?
Yes, we found, I think this is a very motivated group of people. I mean, it is speaking anecdotally from my own clinical experience, and I'm sure you have your own thoughts about this as well, Mike. But in terms of motivation, if you get a terrible diagnosis of metastatic breast cancer, which is a terminal diagnosis, you can kind of fall in a couple of different camps, right? One is, I'm going to do whatever I want to that gives me pleasure with what time I have, and that's totally reasonable. And I don't want to, I'm not going to muck around with, something I don't want to do. And then on the flip side, there's a lot of women that say, okay, well, I want to do everything I possibly can to improve my odds. And changing my food is something that's a relatively low cost to me, so I'll do it. So there's a lot of women that fall in that second group, with this diagnosis, and it's a very motivated group. I think if you look at sort of cohorts of people in the medical system, on average, it's very motivated. So we got wonderful recruitment and wonderful, the feasibility stuff was awesome. Women, we did pretty extensive food diaries, where we did 3-day food diaries beginning and end. We did unannounced 24-hour recall diaries 3 different times in this short time period, which is more than a lot of studies kind of do. But we found that women were consuming somewhere around 95% of all their calories from on-plan foods. And when we look through, we're pretty strict. If it was a food that had any added oil or an animal product, the whole thing was off. So about 95% of all their calories came from on-plan foods, and just about everybody, all but one person met our pre-specified definition of compliance, which was more than 80% of their intake was on plan. So yeah, they really jumped in, did a great job.
Yeah, that's remarkable for a dietary intervention, study. That's
Yes.
one of the challenges. Even when you provide the food, sometimes it's a challenge. Yeah.
Yes.
And under adverse events, there were 3 patients with hypotension, and I actually sort of chuckled when I saw that, because when I lecture patients about making the transition to whole food plant-based, I said, if you're on blood pressure medication, you're going to need to work with your doctor to lower that. And I saw that you had 3 patients you had referred to their doctors to make some adjustments.
Yeah. It was otherwise very well tolerated. It was one of the things, like I said, the reason we did the pilot study is because we wanted to see, is this feasible? Is it going to give side effects? These are women on it's some complicated medical situations on systemic therapies, and we didn't find any problems with gastrointestinal problems that would be a prohibit applying this diet more broadly. In other studies we didn't, and if anything, that was better. And some of the patients who had diarrhea, if anything, it was the surveys suggest that it got better with this diet. So yeah, no, it was very, very positive.
Yeah. So basically the side effects were good side effects.
Right. Yeah.
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 So share with us the results. You found a lot of things when this study. Share with us.
Yeah, well, the primary aim was the feasibility stuff, which I already kind of mentioned. Recruitment, retention, compliance, all extremely good. The women who were generous enough to participate did an awesome job with sticking with it and doing the diet and doing it all the way through the 8 weeks. In terms of other sort of preliminary effects, we found just a ton of stuff for a small little study of this duration. We found, one of the more striking sort of statistical things that was just across the board was weight loss. So on average, our intervention group started with a BMI of just under 30. That means they were just on the border between the categories of overweight and obesity. So they were just at that. So they had some excess weight, as I mentioned back at the beginning. It's a common issue with breast cancer therapy, breast cancer treatment. So they lost about 1.5 pounds a week on average through 8 weeks, without signs of any, cancer progression or cachexia. The sort of that's kind of the wasting associated with advanced cancer. Loss of appetite, so forth. But there was it was intentional weight loss, 1.5 pounds. And then with that, there was a whole bunch of what we call cardiometabolic improvements. So things like cholesterol, which is no big surprise, right? Cholesterol was down about 20%. We also found that insulin was down. Insulin was lower at the end. Insulin resistance was lower. We looked at IGF-1, which is a growth factor associated with cancer progression, a growth factor associated with cancer risks of some of our most common cancers. And IGF-1 was lower within the intervention group from the beginning to the end, statistically significantly lower. And that was, we also looked at some hormonal factors. So we know that sex hormones matter in breast cancer, so we looked at sex hormone binding globulin. This is a protein that we all have in our blood that carries our sex hormones. So if you have sex hormone binding globulin, it's carrying around estrogen and testosterone in the blood. And we found that women who were in the intervention group had a significant increase in this binding protein. So what that means is that binding protein was binding to more of the free sex hormones. We couldn't really measure estrogen because estrogen was undetectable because of treatments and menopause. But we did look at testosterone, and we found that the free testosterone, this is the unbound free testosterone that's just kind of floating around, was lower. So more binding protein was sort of binding to more of this testosterone. And you start looking at these things, insulin resistance and insulin, and all these changes were trending in a good direction, in a hopeful direction. We importantly also looked at quality of life. And so one of our papers, but due to word count, we couldn't put everything, all of these findings in one paper. We also looked at quality of life factors. And so we found that women in the intervention group had a significant improvement in overall quality of life. We used the standardized self-report questionnaires that they use in drug trials of cancer drug trials and so forth. And overall quality of life was significantly improved. It was statistically significant, but also it was clinically significant. If you look at how much the improvement was, it was more than sort of the minimal clinical difference. We also noted, in perhaps most impressively that perceived cognitive impairment was significantly improved across all of our measuring tools. So, you may have heard of this term chemo brain. This cancer therapies are frequently associated with kind of foggy thinking, mushy thoughts, just not as sharp. And it can stay with people after chemotherapy for a while. So it's a serious side effect of our cancer therapies. And we found across all measures, several different reporting measures that the perceived cognitive function was significantly improved statistically and clinically. It was well above what would be sort of clinically important. Some measures of our quality of life, some measures showed some improvement in fatigue. I already mentioned there was one measure showed improvement in diarrhea and bowel function. So quality of life was a very strong finding. We certainly didn't know that would pop up, but we did find several significant findings with quality of life improving within 8 weeks. We did look at, as much as possible, at cancer activity or cancer progression. And the way we looked was a couple different ways, but they were all very, very limited by the duration of the trial. So it was only 8 weeks, and we had a small number of people. So we looked at cancer markers. These are blood markers that represent cancer activity or tumor activity. CA15-3, CEA, so on. And we found that in the intervention group, the cancer markers were stable. In the control group, the cancer markers got a little worse. But it was statistically not remotely statistically significant, because you're dealing with small numbers, and these cancer markers have very wide ranges of possible outcomes. So we just can't really say anything about the cancer markers. It was, I suppose, if there was the change we saw was hopeful, but it wasn't. It could just be random chance, right? What we found. So we didn't. The study is too short, but that's okay. That wasn't the purpose of our study, to see if we could, slow cancer, because this is a feasibility trial. But we saw hopeful signs there. And then jump in if you want to, but there's some stuff that we haven't published that I'm very excited about. That we're still putting together. But the sort of the base of this is what I just said: improved quality of life, improved cardiometabolic function, growth factors, hormones, insulin resistance, and so forth. A lot of this picture was showing improvements.
And the weight loss was central to all this. And the other thing you mentioned in your paper, just that probably, and you can elaborate if you want, but reducing systemic inflammation led to some of those quality of life improvements with cognitive function, fatigue, and that sort of thing, as a result of the whole food plant-based diet. In other words, you didn't measure inflammation markers per se, correct?
Well, we did. It's kind of an interesting story. This is the story of research. We did, but we looked at just general CRP, C-reactive protein.
Okay.
And thinking these are women with metastatic cancer with tumor burden and systemic therapies and so forth, that they would have a high. So that general CRP measures inflammation if it's at like sort of at least a moderate or higher level. Right. It turns out we got women who were on stable therapy. So that's one thing I haven't mentioned. These women were stable on their cancer therapy. We didn't want to get women who are in the process of changing drugs or changing cancer therapies, because then it kind of makes us hard to know what's doing what if all these things are changing at once. So we wanted women stable on therapy. It turns out that women with metastatic cancer who have been stable on their therapy, their inflammatory marker, CRP, is actually fairly low. So that was a choice we made that didn't yield any information, because women's inflammation levels was low enough that it didn't show changes. We know from a lot of other research that this is a very anti-inflammatory diet. And we saw in some of our studies, some of our results we haven't published, we've seen changes in immune system markers, significant changes in immune system markers. So yes, that's a long answer to say that, weight loss and, the immune system and inflammation system was changing a lot of this environment.
Yeah, excellent. So if you want to share some of the findings that you and I talked about before we went on, and then I'm going to ask you a couple other questions about the breast cancer study. And then with what time we have left, I'd like to talk about your type 2 diabetes study.
Yeah. Let me share my screen quickly. And these findings, so the cardiometabolic weight stuff are going to be it's open access. So you find it in the link. One of them is just published online like this week or last week, and the other one is accepted and going to be published online in the next couple of weeks, but it'll be freely available and downloadable to anybody. This is just a sample of kind of the quality of life stuff. We looked at, like I said, a lot of standardized measures. This is FACT-B. This is a very typical measure of quality of life in breast cancer in cancer trials. And we found, this is just an example of the total score. Higher is better in this case. This light blue is the intervention group, and this is the control group. And the dotted line is what's considered clinically significant. So yes, the number's higher, but can people feel it? And if it's here or higher, it is clinically significant. So the overall quality of life, if you look at the quality of life of breast cancer symptoms, it was significantly better. The feeling of physical well-being, the reported of emotional well-being, actually all improved. And then the strongest signal we got was perceived cognitive function. Really, the cognitive function was pretty dramatically improved in this intervention group, the light bar. You see the total score, and then these are just sub scores of this measure. Perceived impairment in cognitive function, effect on quality of life, whether people notice comments from others. And then another measure also showed significant improvements in cognitive function. And some measures, not all, some measures showed improvements in fatigue and energy as well, which is a really big deal for cancer patients on therapy. And let me briefly mention the dietary intake. So, I talked about the compliance of our participants, which are just so wonderful. People jumped in and stuck with it, and this is not lining up right. But anyway, as a consequence of this sticking with it, and what we did with a diet that was much stricter than anything that's been tested before in a randomized controlled trial for advanced cancer, we got enormous dietary changes. So, fat intake went down as a percent of total calories. Fat intake went down 43%. Fiber intake went up just a huge amount. The overall diet actually increased. If you look at the mass of the diet, both solid and liquid, the mass of the diet increased by about 20%, but the calorie intake went down about 20%. And so, knowing how sensitive we were to this weight thing, we asked women, for example, did you get enough food? Were you full? This type of thing. And we, if anything, they felt we gave them too much food. They couldn't finish everything. They couldn't eat anymore. They felt full and satisfied. The taste responses we got were pretty good, and this was particularly wonderful. I think we asked at the end kind of this customer service question, on a scale from 1 to 10, how strongly would you recommend that other cancer patients be given this type of nutrition and support intervention if they were able and willing to participate? And here you see the scale 1 to 10, would not recommend or highly recommend. The average response was 9.5. So almost universally, very well received. And they would, in fact, meant several of our participants, as we got on in the study, came from recommendations of other women who were in our study they were in a support group and they told other people in the support group about our study and they joined. So, there's this perception that just, nobody's going to want to do this. Nobody's going to like that. Why would you do that? And our experience and our response was the opposite, which I'm really thrilled about. We asked them, do you feel that your health has benefited from the study intervention? And 19 of 19 respondents. There's one person who didn't do the questionnaire, but 100% said yes. So, we got some wonderful results there in terms of feasibility and so forth. And then I won't share any numbers or anything because we're still looking at these numbers and writing the manuscripts and so forth. But we did some sort of just exploratory, it's a feasibility trial. So we see all these findings and we're looking, what else was changing, because there's a lot that was changing. So we had an extra tube of blood and we did some additional testing on more exploratory measures of markers related to cancer progression and so forth. And so just as an example, there's markers that are related to blood vessel growth. It's called angiogenesis, and blood vessel growth and angiogenesis is an important part of cancer progression. Your tumors, these disordered mass of cells grows and it cannot do so without a blood supply. And your blood shouldn't really be growing, and blood supply shouldn't be really growing into these disordered masses, but it does. And so, there's been a line of treatment approaches through time where if you cut off the angiogenesis and cut off the blood vessel growth, you can hamper cancer progression. It's the theory, the very rough, simplistic theory of that. But so we looked at markers of angiogenesis. These are for those who may be aware, this is VEGF, several different types of VEGF. And we found that VEGF was lower in our intervention group. So markers of angiogenesis were lower. We found that we also looked at markers of the immune system. So TNF alpha is a sort of inflammatory marker that's associated with worse outcomes. We found that TNF alpha was significantly lower in the intervention group. There were other immune system markers that were lower and improved in the intervention group. There were other markers that I'm certainly not even expert in, but they're associated with risk that we kind of popped out, and those were significantly changed too. So what we found, and then we also collaborated with a wonderful colleague who's an expert in metabolomics, and he did a very nice analysis of looking at amino acids in the blood. So there's a large body of literature looking at methionine restricted diets for cancer, for example, finding some benefit. No, I shouldn't say large body of literature. There is a body of literature looking at methionine restriction as a benefit to cancer. And so he looked at which methionine is an amino acid. So we looked at all the amino acids as they were consumed in the diet. And then we looked at all the amino acids in the blood. And we have found some really quite striking differences in terms of amino acids. Things like glutamate is an amino acid, and that glutamate is a key feeder of cancer. And that was significantly lower in our intervention group. So, what's really amazing and remarkable about our little experiment, there's certainly very important limitations to our little study in terms of extrapolating this to know what's going on with the cancer. But what we found from our little study is quite amazing. For a group of 30, it's hard to reach statistical significance with a group of 20 people. You've got to have a pretty big change. But we hit on a lot of stuff, from quality of life to the cardiometabolic to some of these other really novel, interesting kind of things. And what I think my impression as I've looked through this and written about it and stuff is that we cannot know. Our study was way too limited to know whether this affects cancer progression and how so and how much, or, we can't know that from this study. But what we can see is that, man, in 8 weeks, boy, did we really change the environment, of overall health in going on around this cancer. And we know from a lot of research that's maybe very significant. So, that was kind of the takeaway, I think. We definitely need to do another study looking at actual cancer outcomes. But for now, this feasibility sort of short-term pilot it hit on a lot of stuff. Is very exciting.
It did. That was one of the things that impressed me, is the number of factors that reached statistical significance. It was amazing for that small group.
Yeah, for 20 people, you got to have a pretty big change to get.
You do.
But, and I think that I attribute that to these huge dietary changes. These dietary changes were bigger than anything that I've ever seen published, in terms of how big these dietary changes were.
Yeah. Getting the animal products out, get them on the whole food plant-based, no added oil. It was great. So to close this part out, and then whatever time we have left, we'll talk about diabetes, because it's, again, exciting as well. If you could summarize what you would, where do you want to go from here? In other words, you mentioned some limitations. We need to do this. Obviously you want more people, you want, a longer study period. What would you like to do in the ideal world of research? What would you like to do next?
Well, so there's a kind of a movement or thought that, in a small group of people that aren't plant-based, but they're interested in a holistic nutrition approach, established researchers and so forth. There's kind of a small movement that we need to study nutrition as we would a drug, and that's what we've started doing with our feasibility pilot. But we need a larger sort of very well-controlled, well-matched 2-arm trial where you do a comprehensive nutrition intervention and see what kind of differences you make. And what we need to do now is look at this, take this feasibility and this preliminary effects, and see. The big question, of course, is does this affect cancer progression, or cancer mortality? Are we going to see that this translates into benefits that we care about? No one cares about their level of TNF alpha. What we care about is the cancer and whether it progresses more slowly. And that's what we need to do. We need to do, and to do that well, we need to do a multi-site trial, getting women from various sites and do it for a longer period of time, 6 months, a year, and follow them out over time. And that's of course very expensive, which is, the barrier for people having not done that type of research. Because I would also want to feed them for a period of time and give them food and just a ton of support so that they could stick with it.
Yeah, and that was a clear strength of your study, that you were able to feed them for 8 weeks. So yeah, great. So we have a few minutes, not many, but a few minutes left. Your study, the acute effects of a DASH diet and whole food plant-based diet on insulin requirements and related cardiometabolic markers in individuals with insulin-treated type 2 diabetes. So give us a overview summary, because we have about 15 minutes to do this, Tom. Yeah. So I'm sorry for the limitation, but
yeah, no, this is a super exciting thing too.
It is.
Looking at food as medicine, and does food matter and how much it matters, right? The second question that people always get mixed up is, how do you get people to change, and how do you get people to stick with it? That question can wait for us. We're looking at, does food matter and how much does it matter? Absolutely. So yeah. All of our studies are feeding studies. Basically, we give people food. So there's not much literature. I've treated a whole bunch of type 2 diabetics, people with type 2 diabetes who are on insulin. And the people I've seen people have just remarkable benefits with being able to reduce their insulin fairly quickly when they change their diet dramatically. But if you look in the literature, that's not very well described. What are the acute changes in insulin if you change someone's diet quickly? So that's what we wanted to do. We did a very intensive little study with 15 people, 12 of whom completed the entire study period. But we studied them for a week at baseline, looked at all their blood sugar, their insulin use, their diet. Then we put them on a DASH diet. This is sort of a healthy American diet. Nothing is off the menu, but it's way less red meat, way more fruits and vegetables, lower fat, definitely much healthier than most people are eating. We put them on a week on a DASH diet, and then we switched them over to a strict whole food plant-based, totally vegan, no animal products, no added fats, pure fats, no oils, butters, or solid fats. And then after that, they went back on a DASH diet for a week. And so we did this thing in sequence. We measured a bunch of stuff every week. And just to cut to the chase here, we showed that after 2 weeks, so 1 week on a DASH diet and 1 week on a whole food plant-based diet, after 2 weeks of these plant-based diets, this was our main outcome. Where did it go? There we go. This is their total insulin use. And let me just make a little side note here. The other thing that was novel about this study was we went after subjects that are normally excluded from nutrition intervention research. Not always, but for much of the research that's out there, they've been excluded because they are on insulin and they've had diabetes for quite a long time. On average, these people had diabetes for 12 years on average. And on average, they were on 90 units of insulin a day. There were people on over 200 units of insulin a day in our study. And these people are excluded for 2 reasons. One, when you've had diabetes for that long and you're on, oftentimes you become a little bit more resistant to dietary benefits because of physiologic changes. You do become a little bit more resistant to the benefits of changing your diet. And 2, it's a risk. If you're on that much insulin and you change your diet overnight dramatically, you can really bottom out your blood sugar and have a risk. So we actually called people every single day, every single subject, every single day to adjust their insulin to keep them safe, based on their to review their blood sugars and adjust their insulin to keep them safe. And what you're looking at is their total insulin usage relative to their baseline usage. So this is the relative, that's the 1. On the healthier American diet, the DASH diet, their insulin use went down significantly. But on the whole food plant-based, it went down even more. So after 2 weeks of these plant-based diets, after 2 weeks, their insulin was able to be reduced by almost 40% within 14 days. And then we did this interesting thing where we put them back on a healthy American sort of varied DASH diet, and everything started regressing back to baseline. So if you go from the strict diet to smaller dietary changes, more closer to in the American diet direction, things get a little worse. And that's what we saw. So we also looked at things like cholesterol and inflammation. Inflammation was reduced by 40% by the end of these 2 weeks. Cholesterol was down 20%. Other hormones like leptin, which is implicated in some of this stuff, was down significantly. We did do our glucose tolerances, so their insulin resistance and it was much lower, 50% lower at this point. Really, really big changes. And this is also, of course, very significant limitations in this study. We designed this study for logistical reasons to do it the way we did it. But the way we did it, we couldn't really compare strictly the DASH diet and the whole food plant-based diet because there were carryover effects. I mean, people did a week of a DASH diet and then came over to here. So there were some carryover effects, and they did plant-based and then went over to here. But nonetheless, across all these different measures we looked at, there was kind of the same picture, the same curve. The healthy American diet, moderate changes resulted in moderate benefits. The strict diet resulted in strict, bigger benefits. And then we went back to, slid back to a more moderate diet. Everything kind of regressed to more moderate benefits. And so these things can change fairly quickly, and they change with the degree of dietary change that you make. But the big takeaway, I think, was here just, a 40% reduction in insulin use, even among people who had diabetes for a long time and were taking a lot of insulin. And these people generally are more refractory or resistant to, their body is more resistant to the benefits of dietary change. So, that was, I don't know if that was short enough, but that was that.
You can elaborate more. I mean, I think, type 2 diabetes is so, abundant in the population. And, we know that type 2 diabetes can be prevented, treated, and many times reversed. And your study is, the tip of the iceberg. You're starting to show what we already know, but we need
Right.
the science to convince our fellow physicians that, hey, this really does work, and people would adhere to it, and all these other good side effects that result as well. I mean, like you said, we can't draw any firm conclusions because of carryover effect, but it was pretty suggestive, in all areas. It was really, really, interesting. Diabetes is something that most people blame on their genes, and they don't, recognize the lifestyle factors and those sort of things. So if you were to elaborate on this study and go to, phase 2, what would you do? What would you like to do to, get even more convincing data?
Well, I think we'd need to show that this is just kind of proof of concept, and puts a number to how big the effect can be in the very short term, in terms of affecting some of these numbers, the insulin requirements and so forth. What we need to do is look at it for over a longer period of time, because there's questions about people sustaining the dietary change, right? Can they sustain it? There's questions about the not only the sustainability of the change, but sustainability of the benefits. In my experience, if people stick with it, the benefits continue to improve. So would we see that 40% reduction in insulin maybe go to 60% reduction in insulin, or 80% reduction in insulin, or what, if we went out 3 months, 4 months, or thereabouts, 5 months. So there's very interesting questions about sustainability of the behavior, sustainability of the benefits, but even more, I think if I'm thinking about the high impact nature of this, I'm looking also at the money involved here. Diabetes, as you mentioned, is absolutely prevalent. There's like 50% of Americans have diabetes or pre-diabetes.
Yep.
About 25%, roughly, up to about 25% of Americans with type 2 diabetes require daily insulin, or are treated with insulin. So you're talking about a huge number of people that have pretty advanced diabetes and are on pretty significant medication regimens. If you look at the cost of that, 1 out of 4 healthcare dollars in this country is spent on patients who have a diagnosis of diabetes.
Right.
And the majority of those expenses are because of the diabetes. So, and there's all this, incredible enthusiasm and rush about the newer diabetes medicines, like the SGLT2 inhibitors. These are things like Januvia and things like Ozempic that everyone's heard of, the GLP-1s. These things are like $1,000 a month, So the costs of treating this disease are not necessarily getting any better, and so it's just an enormous personal health issue for so many people. It's an enormous economic issue, absolutely enormous. And if you could show, an intensive dietary, I mean, heck, for the cost of $1,000 a month, if you were efficient about it, you could have a private chef make every single diabetic on insulin, their own private meals, and probably get, some pretty interesting results. I say that to be provocative, but who knows? We should look at it. We should think about it. So that's what I would do there. That's what I'd love to do.
Yeah. Great. I look forward to that, Tom. Yeah. And so, if we look at these 2 studies, you did not take the low-hanging fruit with easy patients. You took the more challenging diabetics, those with advanced cancer, and you showed remarkable changes. So future research is, boy, that's going to be fun to see what we find next. And so, so just quickly, just before we go to the question and answer, for people that, are not familiar with research in general, pharmaceutical or, nutrition, just briefly discuss some of the challenges. You touched on some already, but there are numerous challenges it's not cut and dried like placebo, controlled, pharmaceutical, we're going to test this drug. Nutrition is more complex and more complicated to do the research.
As it's very intensive. So at our research program, we have a chef full-time, and we have a research kitchen at our facility that's, public health certified and inspected and all that and so forth. Human subject research is incredibly bureaucratic. There's a lot of hoops you jump through for everything. It's incredibly regulated, and you could argue rightly so. And in most circumstances, sometimes it's a little overboard, but it's incredibly intensive. And the big barrier is funding. I have to say, without going into all the sordid details, because we don't have time, we've applied for funding for NIH for a larger breast cancer study 3 years running for a multi-site trial, and we've been denied 3 years running. And the sad part is we haven't even gotten close to the funding line where people get funded. And it's if you start looking at it, every researcher can talk about sort of the irrationality of some of their grant applications, but I really think that there's a strong bias against this type of research at NIH. If you look at how these things are reviewed and how they go to a study, what study sections review these things, and there's groups of people that review these things. There's sort of like one study section that reviews most behavioral interventions, and they could be reviewing mindfulness interventions for pain. They could be reviewing exercise interventions for diabetes. They could be reviewing. It all goes to like the same 30 people, and there's not a lot of nutrition intervention expertise in the world, period. So they don't have much there, and certainly plant-based nutrition is even further out from just general nutrition expertise, further out meaning even more rare plant-based nutrition expertise. So you end up getting reviewed by folks oftentimes that are sometimes kind of unaware, unfortunately, of some of the issues, and then it comes down to do they like your diet? Do they see people doing it? And you could probably do a little study. I've often thought you could do a little study where if you had reviewers and you could do a survey of what they had for breakfast and how they scored their dietary proposals, you'd probably find just incredible nutrition, just incredible bias. People have sometimes I wish I was in physics, because nobody thinks they're an expert in particle physics, just walking out of the door. But my God, everybody thinks they know nutrition because their parents told them what was healthy, and all their friends know what to eat, and blah, 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 So it just comes down to being subject to this enormous bias. It's very, very difficult to get funded for this type of stuff.
Yeah. Well said, Tom. Well said. And, I will say here that the promise of this research that you and your wife, Dr. Erin Campbell, and your team, this type of research is extraordinary. It's just amazing, especially through human intervention studies that you are conducting. And really, we, the public, we need to do more. And to further support this, the T. Colin Campbell Center for Nutrition Studies is going to be launching a major fundraising effort. We're going to create a website landing page, which will be available soon. And meanwhile, if anybody on the call or watches the replay, if you have questions or you want to know more, please reach out directly to Leanne Campbell at lcampbell@nutritionstudies.org. You can do that. Natasha, you're going to, can you put that in the chat for those that are on the call right now? lcampbell@nutritionstudies.org. And with that, let's go to question and answer. So Natasha, come on board.
Well, while Natasha's coming on, let me just say that all of this research was a result of pretty large teams of people. So I was one of a large group of people. And so the funders, the T. Colin Campbell Center for Nutrition Studies, the Ladybug Foundation, many individuals, there's a lot of people to be grateful for, and especially the participants. I've been blessed with participants in our studies that
Yeah.
people show up and they just like, here's my arm, give blood. Like, it was wonderful, wonderful folks. So it's a lot of people that have made this happen.
Good. Yeah. Thank you for that comment. Yeah. Natasha, what do you got?
Well, this has been incredible, and the chat has some excellent questions. Just to be clear to everyone, thank you so much for your questions. We're not going to be able to take them all, but we will do our best. So we had a conversation, the doctors and I, before this. What usually comes up in the course of these types of conversations is that we can all point to or may have personal experience with having breast cancer or another illness or a disease, even though we have been whole food plant-based for many years. So is that something that you can speak to, is just diet in general and the effect on human health?
Yeah, I mean, I think if I think of most of the patients I see and the issues that they are dealing with, can you guys hear me okay? Okay.
Yeah.
The issues that they're dealing with, I think of diet actually as the sledgehammer in our toolkit, right? Diet has this enormous effect on a number of things: inflammatory conditions, metabolic conditions, body weight, and then you start changing these other conditions and then other good things flow from it. So diet is incredibly powerful and beneficial, but absolutely it is not a cure-all, and so I'm what I call an all of the above doctor. At some point, even if you're whole food plant-based, you will need to see a doctor. I suppose you don't. I suppose you might not need to. I suppose if you're sort of in the backwoods, off grid sort of thing. But I think people have, I have wonderful expectations and hopes for dietary change for people, but certainly there are limitations, and we don't know where those limitations are until we study it, which is why we're doing the research, because you need the research to know, for example, is triple negative breast cancer going to be responsive to diet? Is it just estrogen receptor positive cancer? Is it breast cancer? Is pancreatic cancer going to less responsive? On and on and on. And we could just millions of questions that we just don't know. And there's going to be bad things that happen to us, even if we're doing all the right things. We never have total control over that, right? So I think I'm extremely enthusiastic for diet and dietary change, but it's not a cure-all.
Thank you very much. There are several questions about the study itself, just a little more clarity. Someone asked, do you plan to continue to study the intervention group who will continue to commit to following a whole food plant-based lifestyle and see if it will have any impact on that small group over time?
That's a great question. Our intervention was designed just to help people change for those 8 weeks. If I was going to do an intervention where I wanted people to change for the long term, I mean, they certainly gave them the tools to continue if they wanted to, but we didn't. If I was going to support people for long-term change on their own, I would have them start cooking for themselves while I still was supporting them and teaching them and so forth, so that they were shopping and cooking and they still had intensive support and so forth, if I really wanted to look at long-term outcomes. So our study intervention was really just looking at that feasibility, that 8 weeks. And preliminary changes. So we're not going to follow people out longer than that. And you have to, human subject research, you have to plan all that out in advance and so forth. So yeah, we're not going to do that.
Okay. And then there was a couple other questions, and these I think will be quite short for you. Within the intervention group, how diverse was the population? And there was another caveat. Was there anyone included in the study who had the BRCA2 gene mutation for high risk for breast cancer?
Yes, good question. I think there was someone with BRCA2, 1 or 2 people, but not enough to understand anything. There's no way to do like a subgroup analysis on 1 or 2 people. So nothing, no observations really of note there. The diversity was a limitation of our study for sure. We had overwhelmingly white women. That was for a couple of different reasons, I think, but it was a limitation. We also had a limitation with our type of breast cancer. So there was a higher representation of estrogen receptor hormone receptor positive breast cancer than the general public. So the general cancer incidence. Part of the explanations with those is that we were looking more for stable people with stable disease that weren't undergoing significant changes in treatment, and disease type, that estrogen receptor positive tends to lend itself more to that stability. It's a little better prognosis, a little more stable sometimes than like triple negative. So we ended up with an over-representation of a couple of different items there, baseline variables that kind of limit its generalizability, we say.
Gotcha. Okay. And then were the positive results in the cardiometabolic factors and QOL controlled for weight loss? In other words, in this study, was it possible to tell if the good effects were from weight loss or from the food?
Great question. I think our study is too small to pull that apart. But we did not look at that, but I can tell you that we certainly our plan hope to do that kind of analysis and pull those factors apart.
Okay. And
if we can do this multi-site trial.
Thus another reason, right?
Yeah.
So speaking of the food, there's a wide range of people who are joining us this evening. Some who are kind of hearing about whole food plant-based nutrition for the first time, and then people who are very, very well educated. So could you share a little bit about the diet itself? Like what people ate, and why no added oils? Was that for the weight loss part, or?
Yeah, great questions, and something we commonly came across. I'm just wondering, I don't need to, I was going to share maybe a table, but I don't need to show that. So, our menu was, for example, we might have a breakfast of muesli, oatmeal with fruit. Our chef makes sort of a parfait, kind of a yogurt parfait with a non-dairy milk and fruit. Lunch might be a bean burger. We might have a peanut soba noodle was one of the dishes, a bean burger, lasagna. I think that was on the cancer menu, but yeah, so that was, those types of foods. They're foods that we try to make them somewhat familiar. Sweet potato enchiladas. We try to make them somewhat familiar, but they are made differently, of course, animal products, no added fats. The no added fat rationale, from a nutrition point of view, is there's some research showing linking fat intake with cancer processes, and but it's certainly not hard and fast. I think there's some stronger research probably with heart disease than there is with cancer, but there is a little bit with cancer. But I think in my mind, one of the biggest factors with that recommendation is behavioral. We want to get the processed foods out of the diet. And if you look at the ingredient label of 95% of the packaged foods in the grocery store, and you'll see oil as an ingredient. And if you can't eat those foods, then you're going to be moving pretty strictly most of the time to whole food, plant-based whole foods. So can I show you evidence that, a tablespoon of olive oil every couple of days in your stir fry is going to do you in? No, I cannot. But from a behavioral point of view, that's what we really were going after, the biggest nutritional changes that we could get. And it's just, it's one thing that you can sort of draw a bright line around, that oil. A behavioral kind of bright line that you're just not going to have food with that ingredient. It's a little harder with other ingredients, like say added sugar. I'm not a fan of added sugar either, but my God, there's like 35 different names for sugar, and they conceal them in every possible way in the label. So if I had to sit there and educate every single person about how to identify added sugar, I mean, there'd just be confusion, and I would get it wrong. People would get it wrong. The oil, though, is pretty clear. You get rid of the oil, you get rid of the processed foods.
Thank you very much. Well, Dr. Holly, I'm going to turn it back over to you. But before I do, just to let everyone know who's joining us this evening and also watching the replay, we will be sending out the replay in 1 week. So do check your inboxes and also your trash and spam folders in case it ends up there. And we will add some information about Dr. Campbell's research and how you can kind of follow up and learn more about it and what's going on there. And we'll try to add some additional helpful information. So Dr. Holly, back to you.
Thank you, Natasha. Tom, this has been a more than informative, more than enlightening. It has been fabulous. So I thank you for your enthusiasm. I thank you for all the hard work that you and Aaron and your team do, because, you know, again, this is tough research that you're doing, but it is critical research to the field of nutrition and disease. So thank you for doing it. Thank you for taking the extra time to come up with these protocols. And I'm really looking forward to phase 2, or the next study on the breast cancer and type 2 diabetes. It's going to be exciting. So again, thank you very much, Tom.
Yeah, my pleasure.
And so on behalf of the T. Colin Campbell Center for Nutrition Studies and Spotlight on Health, I thank you for joining us tonight. Speaking of looking at your emails, in about, 2-3 weeks or so, you're going to get another email about April's Spotlight on Health. So I'm not going to tell you what it's going to be yet. You're going to have to wait. So anyway, good night to everyone. Thank you for joining us, and we will see you next month. Bye-bye.